So usually nothing goes wrong, but sometimes in the process of bringing about back the consciousness, kan, then you akan dapat various problem, kan. Of course, macam apa Guru cakap kan, there's so many factors, right? We're talking about, for example, delirium atau patient tak bangun langsung, kan, yeah. But most of the time patient wake up, right? And certain drugs can make it like hangover effect, kan. Certain drug, you know, patient can wake up quite fresh and without any complications, betul tak? So knowing this in the background actually help you to understand where and how your drug works, even though we would never know for sure 100%, because everything that we know so far is still postulated. Many of these concepts are still sort of like simulation, you know, derived knowledge. It's not like you observe directly, right, what happened, kan? Okay. So going back to one, right, from Afiq lectures, okay, that is very, I think for you, it's very easy to understand, right, because it's like very, you know, anatomy, kan, and then physiology, apa ni, back to the, apa tu, cakap pasal the flow, right, the function of the cell, ada lecture somewhere kan? The basic, the axonal and the dendrites and the, you know, the neuron cells, belajar yang tu. Okay, so that's good. So this is all just, you know, a compilation of the knowledge that you have learned before. Okay, except now you have to focus on, okay, why do I need to know this as an anesthetist? What does it, you know, affect my practice as an anesthetist? Okay, so now it's just that, you know, you just need to extend what you know to like, how can I use this in my daily practice, this knowledge. Okay, so for the first part, anyone have any question? Atau pada pernah baca previous question, soalan mana-mana? Afiq ada ke contoh soalan yang you jumpa mana-mana? Banyak I rasa, tadi tengok balik banyak sebenarnya, especially ICP, CPP, CBF. That's like, you know, favorite topic. And I understand lah, because it's very mathematical, it's easy to explain, easy to correct. You pun, I rasa kalau dapat soalan macam tu, kita bertepuk tangan lah, kan. Nah, cuma, apa nama, there's a few things, apa nama tu, values you would read in the textbook, ada some, you know, few differences, kan. Sometimes dia bagi centimeter water, kan, sometimes dia bagi mmSg. So tak kisahlah, I mean, kalau you boleh measure, it comes in two ways. If you use that apa tu, signal transduction, kan, macam your blood pressure, your ICP, right, then it will come out as mmSg. If you're using that manual, kan, CBP manual tu, you level tu kan semua, itu kan datang sebagai centimeter water. So it's just what measurement tools that you are using, then the value will come different. Okay, then saya nampak ada yang guna apa, kilopascal, kan, per square inch, mmSg. Mana satu nak guna ni? Okay, in our practice, we are so used to the mmSg, or at some level centimeter water. So you just stick to that. Even though your text baca, kalau UK banyak kPa, kalau US lebih kepada PSI, so you just convert je lah. So kalau kPa, 1 kPa bersama dengan berapa mmSg? 7.5. So kalau 4 kPa, 47, 48, 20, 30, 30, okay. So you just, you know, like it's easier. Also with the certain drug, I notice, you know, like I know some lecturer also use like norepinephrine, but in the ward, masa you round, you cakap tu, I bagi norepinephrine. Terkejut orang dengar macam, wow, kan? Noradrenaline, right? So you just use noradrenaline. Yeah, I know, because norepinephrine is North American terminology. Yeah, so kita, yelah, kita baca Stolping tu American, Miller tu American, kan, textbook, right? Apa nama tu, but still, we just tied to our normal usual practice, okay? So noradrenaline. Okay, saya dah digress. Okay, so CNS 1, we talk about, okay, anatomy. There's nothing much to apa tu, to discuss about, except that okay, bila you baca kan, you try to then correlate with the with the, let's say kalau you divide into, kita divide into superficial, which is your cerebral cortex, right? The cortex kan, and then comes the lepas the cortex tu the cortex where all the cells are located. Each one have a different function according to where they are placed. You have frontal, even within the frontal you have the prefrontal, kan? And then you ada apa dia? Yang separate between frontal dengan parietal region tu apa dia? What's that? Tengah-tengah tu. Apa dia? Siapa nama dia? Sejuta siapa? Kan, Fox Assembly yang gantung satu kiri dan kanan. Ya. Apa dia? Sylvian pula. Sylvian dekat tepi tu. Kat temporal. Jari. So you ada parietal, which is more sensory focus, and then you ada occipital, kan, which is also sensory but of a different sensory, right? More pada visual sensory and some other functions. And that's a cortex, right? Cortex. And then coming in, you have the apa dia structure tu? Apa dia? Yang tengah-tengah tu tadi. Tunjuk gambar tadi kan. Even Gloria pun tadi re-show back, right? The structure apa dia? Tanya presenter lah. Apa dia? Cortex. Apa pada cortex tu? Dia panggil apa? Apa pada cortex tu?
What meter?
What's that? Bawah lagi dah lemas. That making the limbic system tu. So the limbic system is what it is, that is a combination between the diencephalous and mes tengah maksud dia, encephalous. So that's tengah-tengah tu. So you ada apa? You ada basal ganglia, kan? You ada apa lagi dekat situ? The basal ganglia region tu banyak lah, kan? Okay. And then bawah pada tu you ada apa? Come back is the brainstem. Okay, brainstem ada beberapa parts kan? Atas, brainstem yang paling atas is midbrain. Lepas tu pons. Lepas tu medulla. Oblong ke atas, balik oblong. Oblong shape, kan? Okay. So basically each one and region dia ada distinct function, but they don't function on its own. It has to be interconnected. They have to be connected with each other because it's a relay of information. Kan? It's an order, right? It's an order of things, right? Kan? So how do they relay this information? Neurotransmitters. So if you look at the whole thing, yang dia punya CPU unit tu kat mana? The whole CPU unit, the CPU of the computer. Kalau komputer mati, walaupun you ada skrin yang hebat, tak boleh keluar kan? Okay, kalau cortex rosak, skrin rosak, komputer tu tak guna lah. Tapi dia wujud lagi tak komputer tu? Literally speaking, you just change the screen boleh function kan? So kalau CPU you mati, so what is the CPU of our brain? Brainstem. Sebab tu brainstem death. Ni kita link balik dekat kita punya practice. So brainstem death is or known as death by neurological criteria, kan? The new termination, the new terminology is death by neurological criteria. And Malaysia punya dah keluar yang baru ya. I don't think akan keluar dalam exam lah for you, but just for the knowledge. So keluar dah yang baru kan, okay. So the criteria is memang brainstem death lah. Because that is, you look at all the function kan. Nafas pun tak boleh. Conscious memang takkan conscious for it. Takkan regain back consciousness because of the reticular formation center is there. Betul tak? Okay. So So this is how I would say that when you read something, kan, oh you know you link back to what you need to know. Okay, again back to CNS 1. Okay, you learn about anatomy. So anatomy and function memang tak boleh lari. So bila you baca pasal anatomy, you can relate ataupun connect with the function of that anatomical region. And I think rather than you learn separate anatomical location, learn it as a region. What does it do? Yeah, learn as a region. Okay. So next, to support this, you need what? You need a blood flow. Kan? To support this brain function, you need a blood flow. And the blood flow is different according to the region in the brain yang kita cakap tadi. Some more work, kan? For example, which region that do more work for the brain? Gray matter, kan? Okay, so gray matters is where the end result is that you're thinking whatever, kan? Okay. So for gray matters, the CBF, if it's activated, kalau you tak activated tu lain cerita. If it's activated, okay, roughly about how much of the flow per 100 gram per minute?
70.
75 to 100 maximum, kan? About there, right? Then to support that information relay, you have this so-called axons, right? Your cable, kan? So this region it doesn't need that much of a flow support. So this region, how much usually? 25 to 50. 50 tu usually dah memang apa? Traffic lah tu, high traffic, okay? So there is a discrepancy between the region, but overall, kita kata global, kan? Overall, on average, what would be the normal flow? Give and take. About 50. So if you draw the graph of the CBF, CPP, ICP also okay, CBF, CPP or MAP, you would always have that straight line, kan? So what is that straight line? Before talking about autoregulation, what is that straight line? That straight line to show what? That straight line to blood flow. So that means in the normal situation, the interest of the brain is to keep the blood flow constant. So the blood flow cannot change. The blood flow is constant. Sebab tu your y-axis tu is the CBF. But what changed? What is auto-regulated? What is auto-regulated? Okay, several blood vessels or vascular resistance, right, is regulated to do what? Maintain apa? Maintain CBF, betul. So apa yang dia auto-regulated tu dengan adjusting that, you see adjusting about the CBR, which is cerebral vascular resistance. So apa yang dia auto-regulated? Pressure. What pressure? CPP. Very good. So CPP cannot be constant. CBF yang constant. What is auto-regulated is the CPP. You are the pressure range, right? So how they regulated this? By adjusting the size of the vessels. If the pressure is too low, what happened to the vessel size? The diameter? Dia vasodilate sikit, kan? Dia vasodilate sikit. So vascular resistance is reduced. Kalau pressure too high, because you nak maintain the same CPF ni, macam pipe lah. If pressure is too high, what you do? You kecilkan dia punya diameter. So the flow that's coming in is same all the time. If pressure is low, you vasodilate. If pressure is high, you vasoconstrict. This is what auto-regulated is. So the range of the CPP that is normal to get the flow going is between CPP
50 to 50.
itu. Itu that means kalau you punya CPP let's say 60, berapa? 70 to 80 range for CPP. Banyak lagi kan range dia, cannot be 70 to 80 saja range dia. CPP
10 to 20.
10 to 20. CPP range dia. Cuba tengok dekat graf mana. Afiq tunjuk Afiq dekat graf, share. Bukanlah share kat situ, share.
Yes,
50 to 150. Besar range dia. Besar range. Sama lah CPP dengan MUP. Okay. Alright. So that is where your CPP is regulated. Maksudnya kalau what we call a critical CPP value is at 50. Kalau kurang daripada tu, something will be compromised. Patient become unconscious, for example, or reduce in consciousness, for example, sebab at the CPP of 50, you tak boleh maintain dah blood flow. Tengok tak? The flat line is the apa dia? The flat line tu blood flow, yes. So kalau pressure dia kurang daripada itu, yeah, this is you guna MAP, but you can use the same for the CPP. Okay, some textbook guna MAP, some textbook guna CPP. Okay, so basically the flat line, you have to, you want to maintain the constant blood flow. Dah kurang daripada tu kan, memang secara logiknya flow pun tak sampai lah kan. Okay, and if you look closely kat gambar selalunya kat atas tu ada gambar apa, gambar vessels ditunjuk. Okay, so what regulate this? Cerebral auto-regulation. Okay, there are many factors that regulate this. Okay, there are many factors that regulate cerebral auto-regulation. Why this is important? Satu, in relation to the ICP, how do you maintain the flow when increase ICP, right? Okay. And how you manipulate. Katakanlah increase ICP just means that you need more pressure to just deliver the same amount of volume, kan? The flow. Okay, flow is what? Volume over time, kan? Just the same amount of volume, you need a higher pressure, right? So how you manipulate this? Okay, satu, you boleh increase your MAP. That's what we learn, right? You can manipulate your MAP. Another one is you try to reduce the brain pressure. Now there are many ways you can reduce the brain pressure, kan? So same thing, knowing about the CBF and how it regulates the CBF is helping us in physiology as well as pharmacology to treat patient. Okay. But similarly, certain anesthetic drugs, soalan minggu lepas, certain anesthetic drug affect the CBF differently, right? So it affect differently via different mechanisms. So saya kata, beside the cerebral auto-regulation, what are the other factors that influence the CBF? It's not the only auto-regulation here.
PCO2.
Okay, very good. So PCO2, chemical, okay. So how does CO2 regulates the CBF? What do we call that? CO2 tu dia affect apa?
Buffer system.
I mean dia affect apa? Dia affect apa? Directly.
Vessel.
To change the apa nama tu? To change the CPP tu. Vessels, very good. Kan? That's the effect. So what do we call that? What do we call this effect of the CO2 and to a lesser extent O2? O2 tu bila sangat-sangat ischemia lah, sangat-sangat infarction, then only it happens. Don't know the effect of hyperoxia, we don't know yet. But certainly hypoxia is not good for the brain. Okay. So what do we call that? The effect of CO2 to the blood flow. Apa nama dia? It is called vasomotor reactivity. Ataupun nama glamour yang lain, CO2 reactivity. Maksudnya the response of the vessels, the cerebral vessels, okay, to the levels of the CO2. Okay. Alright, vasomotor reactivity ataupun CO2 reactivity. Okay, tu mekanisme nama tu. Another mechanism? Temperature. How does temperature directly affect?
CMR2.
By what?
Reducing.
CMR2. Okay, there's a word there, CMR2. Tapi apa dia punya mekanisme dia? What we call this? Apa? Flow metabolism coupling. Okay, but temperature doesn't do anything with the coupling. That is apa characteristic of this mechanism lah. That is couple. Apa nama dia? So you ada cerebral output. So okay, how does CBF is regulated? Okay, satu you ada the big major one is cerebral auto regulation. Then you ada second mechanism which is vasomotor activity, osmotor activity. So the third one is kaitan dengan cerebral auto ni. Apa nama dia? Apa nama dia? Neurovascular coupling. Why neurovascular coupling? When neuron needs to exert its effect, what does it need? Boleh pakai je apa nama tu metabolism flow, but it doesn't seems like very apt. So apa maksud dia neurovascular coupling? Neuron needs to perform the task, right? What does it need? It needs what? Energy. Kat mana tak energy tu? Daripada blood flow. So kalau dia nak perform something, macam saya tengah bercakap kan, berfikirkan, okay, my brain, tak tahu which part, but my brain needs the energy to function. So my brain bagi respon, cepat datang. So the vascular pun datang within millisecond respon datang. So flow. Kalau saya ambil CT scan saya sekarang, certain region akan flash up. Because it responds very very fast to the needs of the neurons. Okay? So bila saya tak perlu dah brain saya rehat, taking a break, flow pun kurang. So this is what coupling means. This is what coupling means. Couple means the need coupled with the supply. What is the need? The neuron needs, which is the neuron cells. And the supply comes from where? The vessels, the flow. So in all time, memang dia akan couple. If I need more, the flow will be more. If I need less, the flow will be less. The problem is in brain injury, kan, you do not want the flow to be a lot. Nanti edema lagi teruk. Betul tak? But because of the loss already of this relationship, kan? So one way for us to control the volume, the cell volume, is by tarik balik the flow. So how to do that? Kita pun diamkan the brain, rehatkan the brain. So kita reduce this requirement of oxygen, so-called oxygen, metabolic requirement. That's what we say, we reduce the CMRO2. How do we do that? We induce using pharmacology. Now certain drugs memang dia dia doesn't disrupt this coupling. We do not know in an injured brain. In normal brain, macam saya dengan awak yang normal ni, kan, kalau sampai dapat anesthesia, you bagi drug, right, it will matching. Maksudnya the reduction in the requirement and reduction in blood flow matching. So the coupling is maintained. Contoh drug, very good, propofol. Dia maintain je. Okay, dia maintain. How does it do that? How does it maintain that? Macam mana dia maintain that?
Hyperpolarize the brain cell.
Okay, so mula-mula bila kita bagi propofol, what happened to the consciousness? Okay, patient become unconscious, right? Perlu ke sel tu digunakan? Nanti cakap pasal what is consciousness. Perlu ke digunakan? Tak perlu, right? Okay, so tak perlu. So cell is okay. It is already rendered basically bukan kata useless lah, but not needed anymore, kan? Then what about the blood flow? How does propofol reduce the blood flow? Apa efek propofol? How does it reduce the blood flow?
Vasodilate tu.
Yelah, dia vasodilate. So how does it reduce the blood flow? Various
Reduce.
mechanism, direct effect on the brain as well as systemic effect. So the rate at which the blood flow is reduced and the rate of which the effect of GABA, which cause hyperpolarization too, is sama rate. Sama rate. Kalau yang ni 20 yang ni pun 19.5 ke 21.5 ke macam tu, lebih kurang sama rate. That's why we say that it's maintain the coupling. Nampak tak? Boleh bayangkan tak? Boleh bayangkan? Tak boleh bayangkan Macam mana saya nak cerita Okay, effect of propofol kat mana? GABA. Apa GABA tu buat? Hyperpolarize. Apa jadi kalau hyperpolarize? Yelah, dia macam blunted lah kat patient, unconscious lah. Okay, unconscious. Okay, that's one effect right? So that is effect on the neuron, right? Okay, nothing to do with the blood flow yet. So now, neuron dah tak perlu dah flow yang banyak. Bukan dia rehat dah kan? Dia dah rehatkan the brain, right? So, now the blood flow ni kita nak buat macam mana blood flow ni? How do we reduce the blood flow?
Reduce cardiac output.
What does propofol do to reduce blood flow? Okay, propofol kan dia reduce the BP, reduce the heart rate, so reduce the cardiac output kan? That's on the systemic. Even on the brain bone, it cause vasodilatation. So dia reduce that blood flow. Result dia reduce blood flow. So the way dia reduce the blood flow and the way dia reduce the conscious tu sama rate. So the coupling is maintained. Tak ada kata yang ni lebih, yang ni kurang. Opposite that you have is your inhalational agent. Inhalational agent. So macam mana inhalational coefficient? So we know already it's not coupling anymore, right? No couple anymore. So same thing, effect on the GABA plus the other receptors, K2 4 channel kan, semua tu. The result is that unconscious, right? Patient unconscious. Okay. Now, reduction in the blood flow, how does it happen? Dia reduce ke tak? The blood flow. Dia reduce. Kenapa tak pula? Dia reduce the blood flow. Systemically pun because vasodilatation, reduce the MAP. Tetapi the reduction is less than the propofol. So in effect, CNS effect ni dah macam ni, tapi blood flow dia turun macam ni je. So dia dah tak sama dah. And this is being proven from the CT scan, PET scan. Saya tak ingat on dog atau on human. I think on human. Dia compare propofol dengan sevoflurane. So boleh nampak reduction in blood flow yang sevoflurane ni tidak ngam-ngam dengan dengan the scan yang dia buat tu to reflect the loss of consciousness lah. Duk macam ni So dia dah lost dah coupling, dia tak macam ni. Propofol dia turun macam ni. Nampak tak? So that's what it means by uncoupling. Maksudnya the reduction in both the neuron side and the vessel side, or the metabolism side and the flow side is not matching anymore. Yeah. Boleh?
Efek dua-dua cuma yang tak ada.
Efek dua-dua, tapi yang ni kurang, yang ni lebih. Maksudnya yang ni tidak sekurang macam ni lah. Okay? Boleh. Vasodilatation yang cakapkan tu is MAC dependent. So if you use dua MAC, memanglah instead of dia vasoconstrict, dia vasodilate lah, ataupun dia tak ada effect sangat, dia vasodilate lah, then you increase the ICP. Otherwise, kalau you guna even less than 1.5 MAC, it won't cause any increase in the ICP. Inhalational, except for certain agent lah. For example, no, not that. Desflurane ada cache dia. Desflurane usually we keep 1.2. Less than 1.2, okay. More than that, it can cause vasodilatation. So increase your ICP, right? Because vasodilate means more volume kan. Compared to sevoflurane, yes, you are right. If talking about the CDF, betul. Desflurane memang causing that tendency to cause more vasodilatation compared to sevoflurane at equi-MAC, same MAC value. But most of us kita guna 1 MAC kan. So in Euro, or if you have better agent, propofol, bolehlah resort to propofol, because we know propofol is maintaining the coupling even in the brain injured brain. Okay. Alright, so kita cakap pasal CBF, right? And then ICP, okay. ICP usually question datang about Monroe-Kennedy doctrine, kan? About there. So there's a 3 component in the brain that is within the rigid skull. Okay, some texts bagi proportion berbeza. For me it's 70-15-15. Okay, 70 parenchymal, 15 CSF, 15 blood. Okay, some texts bagi 80-20, 80-10-10. Okay, so usually blood and CSF are equal. Okay, so if you look at it, the one that's very yang problematic is the parenchymal, because there's no way for brain, there's no wriggling room, there's no way the brain can shrunk itself, the tissue maksud saya. So the only ways that the brain can adjust adjust the pressure by compensating increase the pressure is by using CSF dengan blood. But between blood and CSF, which one is more efficient? CSF. Sebab blood maksudnya you kena facilitate the drainage dengan cepat. Mana boleh, drainage is a passive process. Dia bukan macam artery, you bagi ubat kan, you boleh improve the delivery, increase the pressure, right? Artery system. Venous system, drainage is very passive, kan? So how can you facilitate the drainage? The venous system drainage? Buka kepala lepas tu suction itulah kan? Yes, by elevating the head, so that gravity tarik, so turun macam tu kan? And kalau which tu ventilated, not increasing intrathoracic pressure so high. So that's where the peak comes. Yeah, because increase peak, increase in the intrathoracic pressure. Increase lagi peak, nanti kan pressure tu naik, flow pun tak boleh turun. Kan? So that's the only way. So not efficient system. So the best is the most efficient is by CSF. Okay, even though CSF pun 90% is drainage through what? Dural sinuses juga. The sinuses tu is all dural sinuses, deep and superficial, kan? And then they all coming together through the IJV, kan? Okay. So how the brain adjusting or compensating for the increased ICP is via the fluid. Failing that, then you are in decompensated state, right? Failing that, then there's no more. Then the parenchyma has to go somewhere, so they put herniation. It can be herniated to the other side of the brain or atas turun ke bawah. What we call transtentorial herniation. Tu memang death signal lah tu. Yeah? Or impeding, memang tak ada cara lain melainkan surgical intervention to release the pressure. Okay, so you need so ICP. Okay, I tak sure lah year 1 yang ada ke tak ICP pressure. I'm not sure. Ada ke dalam syllabus, saya tak ingat dah. Pressure waveform for ICP. ICP waveform. Zaman saya dulu ada. Keluar soalan lagi. That was my question. That was question for me. ICP waveform. P1, P2, P3 tu. Belajar je lah. Saya pun tak ingat lah. Kena double check balik. Because new syllabus, right? So apa nama tu not quite sure. Tapi it makes sense lah kalau you all kena tahu. Pressure waveform, okay? Pressure waveform related to ICP, okay? So you can see the pressure changes with the increase in the ICP. Why we say that? When the brain is decompensated, okay, the waveform now change the shape. But it's not difficult at all. Bila you belajar pasal ICP waveform, you kena tengok bersama dengan you punya IABP. Sebab it's correlate. Okay? So that peak from the IABP is corresponding to the P1 of the ICP waveform. Kenapa P1 tu boleh wujud? Sebab ada room dekat brain. Your vessel has a space to pulsate, kan? Then wujudlah the P1. Okay, lepas tu you have the P2, sama macam you punya IABP. Okay, the tidal tu kan. Okay, so that's P2. Okay, so bila masa P2 lebih daripada P1, what happened? Is it P2 lebih daripada P1 ataupun P1 to fail to rise? You rasa is it because P2 tu tinggi lagi ke ataupun because P1 to fail to rise? Ya, sebab space dah tak ada. The brain becomes so tight, there's no way your vessel can pulsate more. So P1 memang tak tinggi lah. Sama ada dia sama ataupun dia tenggelam sikit daripada ni. Tidal wave is always the same because it's tidal kan, it's reflection kan. It's always the same the same amplitude. Okay? So that's why bila you tengok dalam graf kan, nampak seolah-olah macam P2 is higher than P1. Whereas in reality is the P1 fail to rise because the brain now is so tight. Yeah? Increase ICP. So that's the waveform. Okay, so selalu keluar pasal ICP ialah pasal Monroe-Kennedy doctrine. Okay, regulation what causes increase ICP. At year 1 dia takkan tanya management. So because kita tak perlu tahu, I mean no need to burden your brain with extra information lah kan. It's all about the pathophysiology and physiology, okay, and maybe application of physiology. Okay, so that's usually question about the ICP. And about the CBF, usually about the factors that control CBF. Yang kita cakap tadi kan 3 factors tu, ingat semua? Ingat semua kan? Apa dia? CA, very good. Lagi? BMR, lagi? Okay. So, saya rasa dah habis dah. This is the main thing on one lah. Okay, and then about the spinal anatomy, the difference different parts of anatomy. Why? Because sometimes when you have a spinal cord injury, okay, there's a level of injury kan corresponding to the level of the disability lah kan. Okay. And also when pasal spinal cord, kita ada high spinal cord and lower spinal cord kan, and it has something to do with the cardiac accelerator. Okay, itu di segi anatomy lah. Okay, then we cakap pasal spinal cord memang tak lari daripada autonomic nervous system lah, so always couple together. Okay, blood supply pun okay, always couple together. And then spinal cord perfusion pressure pun sama juga, MAP minus the CSF pressure. So typically sama macam dekat the brain lah kan. Okay, so that's about the
Kerana boleh CPP equal to MAP. Macam mana CPP equal to MAP?
CPP tak equal to MAP. The graph you can use similar. Ganti CPP dengan MAP sahaja. Faham? It's not that CPP equal to MAP, but the graph tu similar shape, similar presentation. Okay? Alright. Sebab apa? Yang dia auto regulated tu is the CPP. That's why CPP tu ada range kan, daripada kecil sampai besar kan. It's auto regulated. The mechanism of auto regulation is by the manipulating the CDR. Atas kalau you tengok ada satu graf kan, yang ada size vessels kan. So that's the CBR. So what remain constant? CBF. Tu je you perlu you perlu faham. Okay. So CBF in any situation should not change. They should remain constant. Okay, baik. So next one kita cakap pasal consciousness. Okay, let's try to answer the question. Glorian, cuba bring forward the question back. Okay, yeah. What is consciousness? You and I both conscious. But philosophical question tak, philosophical juga ya. So what is consciousness? Apa dia? Apa elemen yang penting untuk kita kata someone is conscious? Okay. Elemen nombor dia kena aware. That's the sense of, apa maksud aware? Apa maksud aware? Aware ni maksudnya it's a subjective experience with regards to the surrounding. Kan kata aware of the danger, beware. Kan? Aware. Okay, itu elemen yang pertama. Kan? That's awareness. Elemen yang lain? Responsive. Okay, any other words? Okay, responsive. Any other words? Which is nanti kita relate dengan sleep. That words, okay. So, apa?
Arousal.
Arousal. Arousal. There are different types of arousal. We're talking about arousal of the consciousness. So, arousal conscious. So, apa maksud arousal tu? What does it mean, arousal? Apa arousal? What does it mean? Satu is awareness. Kan? Awareness. Satu is arousal. You can be aroused but not aware. Okay?
Sensation.
What is arousal? Respond to stimulus, okay, is apa, if you measure kan, so that's respond to stimulus, certain stimulus, okay. Lagi, apa lagi? So it's reactive, right? Something that's reactive kan? Alertness, you can say. Arousal is alertness or wakefulness, as opposed to asleep. So we're talking about sleep and awake, kan? We're really talking about arousal state, non-arousal state. Okay, so consciousness, these two elements. Okay, and the process that bring about consciousness? Ni lah, these two process lah yang kita kata. Okay, so one more for each. Okay, and then what is sleep? I can, apa nama tu? Cakap nanti lambat pula. So you ada consciousness. What make consciousness? There are two elements kan. One is awareness. Another one is arousal. Okay, so plus right? Benda ni kena wujud kan? At the same time to make someone conscious, right? Okay. Now what about sleep? What happened to these two? Loss of awareness. Not lost but reduced. So in sleep state, two of these is reduced. Kan? So bila dia positif, dia cause consciousness. Bila dia negatif, dia cause sleep. Okay, now we're talking about sleep. Okay, so sleep is what? Is it natural process? Natural. What else? Reversible. Lagi? Boleh ke saya paksa you tidur sekarang juga? So self-regulated. Kan? And then apa lagi? They rely on the sleep-wake cycle, or what we call this apa? Circadian cycle. Kan? Okay, it's controlled by what? So this is also factors that control juga lah sebenarnya SPN sleep, and it's controlled by the there's a homeostatic apa nama tu control of the sleep as well, right? The homeostatic apa tu control of the, just like everything else lah, homeostatic control. Okay, this we're talking about what organ, what you need that, you know, have a homeostatic control of the sleep. Okay, type of sleep or stages of sleep. Sleep, okay. Lepas tu kita kata type lah, type. Okay. Phase actually, phase. Phase of sleep. Ada berapa? 2. Saya start dengan non-REM dulu because you always start with the non-REM. Non-REM and then REM. Okay, you always start your sleep cycle with the non-REM. Okay. So, non-REM ni ada berapa stages? Okay, actually ada 3 je. Yang 4 tu dia merge together with the 3 and 4. This is the latest one lah. I mean not latest pun, but almost 20 years ago. Okay, so you ada berapa? N1, N2, N3. Okay, so saya draw kat sini satu line, okay, kat situ, okay. So we always start with the non-REM. So dekat N1 yang terjadi, baru-baru je nak sleep. You awake sekarang, what? Okay, if we look through progression of the EEG waveform, awake is what? What wave? Beta. Kalau kat sini kata alpha man kan, ni beta man. Beta is the way you open eyes, you thinking about something, yeah. So dia punya waveform tu apa? Frequency is it can be irregular lah sebab frequency tu memang high, dia memang dia low amplitude but dia high frequency. Okay, so you in a beta, but then when you in N1 state, then it shift to what? No. Shift to what? N1 ni macam baru-baru nampak bantal, dia baru letak ke kepala, dia mimpi sikit, apa semua kan. Alpha. Dia reduce dah dia punya frequency. Frequency is reduced a bit. Amplitude still maintain the same. Okay. So this is at N1. That's saya tak kat sini. Okay lah, N1 kat sini. Okay. Then as you go deeper bit, jadi N2. What happened? Shifted to theta. Okay, so N2 kat sini. Okay, dan dia pegang kat sini kan. Okay. And then now, this one kalau saya panggil you, saya ketuk ke apa ke, you bangun tak? Boleh bangun lagi. This is where it's still like arousable. Dan dah jadi macam sangat-sangat deep sleep. You pergi kat level sini kan. Tu setengah jam pun mungkin tak bangun kot. Yeah, totally deep sleep. So arousability is very minimal. So now shift to what shape? Delta. Okay. Now lepas ni nak kena pergi ke REM. So this is dah finish kan, non-REM kan. So macam mana dia pergi dekat REM? REM tu apa? By the way, okay, we know rapid eye movement. But what happens? Kalau you buat EEG, guess what wave you akan dapat? Almost near beta, but alpha beta. Okay, so like you know alpha beta, alpha towards beta stage. Okay, kan? So which means dia duduk kat sini, right? Kan? REM mesti duduk kat sini kan? Duduk kat sini lah, alpha beta. Macam sangat. Duduk sini kan, mesti dia REM. REM sleep. So macam mana dia bersini nak pergi ke sini? Sama tengah shock mimpi ni. Vivid dreams. Dia dreams tapi dia tak boleh add on the dreams. Sebab apa? Apa lagi karakteristik of the REM? Masa paralisis. So dia mimpi bunuh orang ke apa ke, dia mimpi je, dia tak boleh buat apa-apa because there's a masa paralisis. Maksudnya brain dia je burning kan, dia tak boleh. So siapa yang sleepwalking tu bukan REM lah. Okay. Alright, so this is there's a paralysis. Okay. Okay. So daripada N3 macam nak pergi ke REM, dia kena pergi balik kepada N2. Masuk sini dulu. Lepas tu baru dia pergi ke REM. So daripada N1 kan, N1 pergi kepada N2, pergi kepada N3, pada N3 pergi balik kepada N2, dia tak pergi dah N1, dia pergi kepada REM. So this is one cycle. 1 cycle of sleep. For healthy sleep, how many cycle of this non-REM and REM yang you perlu? 4 to 5. Then you bangun pun fresh, kan? Tak tahu bila last bangun fresh macam tu kan? Pergi holiday pun, balik holiday you pun kena cuti lagi, post holiday cuti. Sebab penat lagi semua kan, tunggu flight delay, stress lagi, extra stress. Betul tak? So this is the sleep cycle, okay? So one cycle complete until sini. So you have about 4 to 5 of the non-REM and REM cycle, okay? To complete, like, you know, make like a healthy sleep, which is you can measure actually. So you can measure the quality of sleep, and someone have this disruption kat sini, memang you can you can relate lah kan, depression, even the chronic fatigue, okay, and then that could be the base of so many illnesses. So good sleep is very important. I'm not saying you mattress or pillow, but investing in good, good environment, lampu ke whatever lah, so this is the sleep cycle, and this is controlled by satu homeostasis, satu lagi sleep wake cycle or circadian cycle. So you ada sleep promoting pathway, and then you ada juga wakeful promoting. So siang hari, daytime, this one yang predominant. That's what circadian means. Malam, this one sleep promoting ni akan dominant. Okay, this one dia bergantung kepada apa? Adenosine. Kalau you minum kopi, guess what happens? You suppress the adenosine. So, ada semua orang sensitif lah. Kalau macam saya dah minum kopi pekat pun pukul 8 malam, tidur lepas tu okey lah, itu dah apa tadi kita sif kata pergi dah, itu dah tolerance dah, different story. But ada orang sangat sensitif. So coffee can antagonize the adenosine. So adenosine kan dia promote the sleep, right? So sleep tak jadi. Okay, this one there's so many there's so many factors. CN ada, dia ada TMN ada, banyak lagi factors ya. The main one is acetylcholine juga. This one acetylcholine sebab adenosine, this one acetylcholine for wakefulness. Okay. So this sleep. So how does anesthetic agent So for the sleep promoting ni kan, dia ada satu region je, which is at the hypothalamus. Hypothalamus kan, nama dia tu VPLO, nama tempat dia. This one yang promoting sleep. So siang hari dia punya firing dia sangat low kat sini. So siapa yang suka tidur siang hari tu saya tak tahulah firing dia macam mana kan. Or could be this one is being suppressed rather than this one is being enhanced. Sebab dia work interrelated kan. Dia bukan kata yang ni independently, tak. So the circadian cycle determine which pathway akan activated based on the time. Sebab tu kita kat Malaysia selalu 12 jam malam, 12 jam siang kan. Bayangkan negara yang sama, kutub utara, kutub selatan, siang 24 jam, winter 24 jam. Hewan ya kat dia punya tu, betul lah. And then there more depression kat sana kan, because your sleep cycle is already been disturbed and disrupted, right? Yeah. So but the main thing is that for the sleep pattern, these are the regulations, okay? So kalau anesthesia, apa jadi pada sleep? Which one do you think? Oh, by the way, beside ACH ada juga GABA. GABA can work promoting as well as inhibiting kat sini pun ada juga GABA yang datang input. Datang input juga. So both GABA can work and they can be switch on and off for each other. Okay, but different system. Maksudnya different pathway lah. But use the same money, same currency, which is GABA. Okay. So where do you think our anesthetic works? We know lah kan, through this one lah kan. So reticular formation tadi tu penuh dengan benda ni, sleep promoting and wakeful promoting. Except for sleep promoting, which is at the hypothalamus, the VPLO, the wakefulness promotion, promoting agent ke promoting nucleus, promoting location, terletak semua dekat reticular formation. And that's where our anesthetic agent works on. So our drug is not so much dia promote the sleep, tapi dia prevent the wakefulness. Dia suppress this one. Sebab tu our patient will not get this normal cycle of sleep, because it's not natural sleep. We prevent the wakefulness of the sleep. Betul apa dah ni, dia punya apa tu? Saya punya ni. Okay. Okay, boleh. So sleep, consciousness, to awareness and arousal. Then what is the characteristic of sleep kan, and then the regulation of the sleep phase of sleep. Soalan tu mungkin tanya, what are the EEG changes during the this both REM and non-REM. So dia cerita macam ni lah juga, the changes, okay, corresponding to the ni kat mana-mana you boleh cari ni. Bukan saya mencipta benda ni, I just summarize sahaja. Okay, alright. Kalau nak yang bukanlah complicated, nak yang detail version sikit, agak Mila ada. But I think this is enough lah cukup. Okay. Okay, so dah menjawab soalan tu kan, dapat makan penuh 10. Aduh. Okay. Saya ada sebenarnya nak bagi juga soalan pasal sleep, tapi dah buat sleep kan. So ada satu je lah soalan tinggal.